Good afternoon, or good morning, or good evening, wherever you are watching from. Welcome to the National Organization for Rare Disorders webinar, Navigating Diversity, Equity, and Inclusion in Rare Disease Nonprofits. My name is Debbie Drell. I'm the Director of Membership at NORD and your facilitator for this meeting. Thank you for joining us to discuss how diversity, equity, and inclusion play a critical role in today's healthcare environment, and how health disparities are affecting marginalized communities in the rare disease space. We're so excited to help you learn from the subject matter experts that we have assembled for this panel, and we will also be bringing our member organization experiences as well. Because this topic is so important in the rare disease community, we have made this webinar open and accessible to the community at large. So it's not just for our member organizations, but for everyone. We want to help inspire all nonprofit leaders to take action and to learn. This meeting is being recorded and will be made available shortly after this webinar. NORD's mission is what you can see on the slide here. NORD is an independent nonprofit leading the fight to improve the lives of rare disease patients and families. We do this by supporting patients and organizations, accelerating research, providing education, disseminating information, and driving public policy. Leaders of NORD's over 330 member organizations are entitled to all the resources that NORD provides, including state-level advocacy, federal policy, our communications, public awareness, education initiatives, patient assistance programs, natural history registries, research, CME, and on and on. Whatever NORD does, we pass it on to our member organizations and to the community. Want to say thank you to our sponsors for helping us to bring this webinar series, make it a reality, and supporting our member organizations and nonprofit organizations in the rare disease space. Thanks for your support and contributions to all that we do. And now you can see our membership team. We are working for you. Your organizational mission is NORD's mission. During this webinar, an issue raised or topic mentioned may prompt you to think of a question that does not get specifically addressed. Any one of the lovely ladies on the screen before you are available to help answer this question or your questions after the event is concluded. I encourage you to reach out to any one of us by emailing membership@rarediseases.org. And a shortcut, if you didn't know, first letter of our first name plus our last name @rarediseases.org. So you can email me directly at ddrell@rarediseases.org. So what are we doing? Why are we doing it? NORD has a long history of incorporating diversity, equity, and inclusion in its work and continues to be committed to increasing access and services to ensure that we are constantly reaching diverse populations impacted by rare diseases. We work to expand access to all in the community for whom we advocate, and that includes Medicare, access to telehealth. When my sister was diagnosed with a rare, life-threatening heart and lung disease, it was almost too late for her. At the time, she was living in rural Texas, the mom of 3 small baby girls, and she faced gender and ethnic discrimination. As a young Mexican-American woman, she saw 12 different doctors, and they told her things like, it's in your head, or it's just stress, exercise more, I can't do anything for you. She was on the verge of death before she was finally diagnosed. And ours was a lucky story because she was diagnosed. Our family story is one of 25 million Americans. If you're leading a rare disease nonprofit organization, your community's stories will vary. But we are unified together in our goal for the future. We want early and accurate diagnosis for all. We want support for all. We want information and education for all affected by rare diseases. The best clinical care, better outcomes, treatments, and cures. I, along with the entire staff at the National Organization for Rare Disorders, are working to provide a future with support, education, research, treatments, and cures for every single person affected by rare diseases and their families. It's not just in our history, it's in our present, and it's a significant part of our future. Through NORD's membership team, we can provide capacity building tools, training, resources, networking opportunities, and leadership development to help us achieve all of these areas for diversity, equity, and inclusion. So next, we'll take a moment to just define diversity, equity, and inclusion and what this means for NORD. Diversity is defined as the representation of all individual attributes and identities. This is what you see on online forms and registration, race, ethnicity, gender, but also disability, sexual orientation, gender identity, national origin, tribe, caste, socioeconomic status, thinking and communication styles, and collectively and individually. We believe when we prioritize diversity, we are able to help our organization and our members and the patient communities we represent to pursue their mission and goals more efficiently and effectively. Equity is defined as fair treatment. That's equality of opportunity, equality of access to information and resources for all. And this becomes possible when we build an environment rooted in respect and dignity. It becomes possible when we take action to ensure equitable access for all communities. Inclusion refers to behaviors and actions that create a culture of belonging and a sense of value for all who participate and contribute, while at the same time understanding no one person can or should be asked to represent their entire community. As an umbrella organization, our job is to best represent and support our 330 members and the 25 million Americans living with rare diseases, and to help each organization and patient community fulfill their mission of advancing researches, finding cures, and supporting their communities, in continuation with our commitment to diversity, equity, and inclusion. And in response to our members' interest in this area, we have developed a foundational series of webinars that will address how marginalized groups are impacted by rare diseases and what we can all do, all of us as leaders in this space, to improve the lives of people living with rare diseases. This webinar is the first of a 3-part webinar series. So the second part is a week from today at 2 p.m. So save the date, Wednesday, November 3rd. Can't believe we're already in November, that we will already be in November. So the second is focused specifically on inclusion. It will feature breakout rooms. So while we're not able to have breakouts in this webinar, next week, we will be breaking out and having small group conversations. We'll be highlighting very specific things: clinical trial engagement, marketing, communications, outreach. There will be a breakout session para hispanohablantes. So the Spanish-speaking communities of leaders are welcome to join us in this webinar and all webinars, and we will have a breakout for this population as well. The final presentation in the series will focus on diversifying your leadership and strategies for board assessment and recruiting and engaging diverse board members. So we hope to see you there, and please register in advance. It's every Wednesday starting today and in the next 2 weeks at 2 p.m. Eastern Standard Time. So we'll go on to our agenda. During this webinar, the agenda starts with some presentations and conversations and ends with a Q&A. DEI, as you will learn in these presentations, it's a constant journey. There really is no end point. We will continuously have work to do as we strive to make the rare disease space more equitable. Please remember that it starts with intention and the commitment to act to really make a difference. With that, I'd like to hand it off with our moderator and first presenter, Dr. Yolanda Avent, founder and CEO of Avent Diversity Consulting. Dr. Avent has been working in the field of DEI for over 20 years and brings a wealth of experience working with organizations. She received her bachelor's in history from Virginia Tech, a master's in criminal justice from Armstrong Atlantic State University in Savannah, and she completed her PhD in curriculum and instruction from Virginia Tech in May 2021. Her content areas include, but are not limited to, racial equity, implicit bias, identity development, microaggressions, conflict resolution, and emotional intelligence. And she has worked in the areas of higher education, staff development, leadership development, diversity for over 20 years. We're so thrilled that she's here to start off the series and share her experience. Thank you so much for being here, Dr. Avent. I will pass it on to you.
Thank you, Debbie. I'm excited to be here today to share some of my experience and perspectives with you around inclusion, diversity, equity, and accessibility. My name is Dr. Yolanda Avent, and I'm with Avent Diversity Consulting, LLC. Next slide. My pronouns are she, her, hers. I do prefer my name, and I share with you 5 of my primary identities. These are not the only identities that I hold, but they are some of my more salient identities. And I always share those because I think it's important for you to have a lens in which I see these perspectives and how I see the DEI, diversity, equity, and inclusion work that I do. I'm a Black woman, which is very uniquely tied for me. I'm a mother. I'm a learner, and I'm also old school hip hop enthusiast for any of you out there who like hip hop. One of my favorite quotes is, "We must always take sides. Neutrality helps the oppressor, never the victim, and silence encourages the tormentor, never the tormented." And that is from Eli Wessel, who is a Holocaust survivor. Next slide. I want to acknowledge a few things as we go into conversations about diversity, equity, inclusion, justice, accessibility. All of those terms is that these conversations can be uncomfortable. And sometimes they can be emotional. They can bring up emotions for people that you may have never felt before. I want to also acknowledge that as I talk about implicit bias, everyone has implicit bias. No one is exempt from having implicit bias. Implicit bias is not all created equal, but we all have it, and it's important to understand the roots of where implicit bias comes from and how it's also manifested. It is also important to acknowledge that everyone's contributions to these conversations are shaped by their individual beliefs, your values, your experiences, all of the things that make you who you are, and however many years old you are as you sit here today, those are the things that have shaped you in your belief systems. And sometimes we have to unlearn the things that we also think we know. It is not always easy to see things from different people's perspectives because of the blind spots that have shaped who we are. But it is important that we acknowledge that we can, again, unlearn those blind spots and start to uncover to see things from different people's perspectives. Next slide. So I want to go over some common diversity, equity, and inclusion terms. It's important that we use terminology and language to empower people. And so as we think about words and terminology as we go through this presentation, I want to first define out a few. The first one is diversity. This is the one you've probably heard the most. You've probably heard this a lot. What is diversity? We know that it is difference, right? It's psychological, it's physical, it's social difference. It can be things such as race, ethnicity, nationality, religion. It can be your immigration status, your language, even body size and type. We don't always think about that, but body size and type is also a type of diversity. The important thing about diversity is it's just the composition of difference, but you have to do something with that difference in order for it to be actionable and make a difference. So it's a foundational step and it's a first phase. So it can be diversity within your community, your organization, but the fact that it exists is important. And then now what do we do with it when we have it, right? And so next slide. Inclusion. This is when you're taking the diversity that you have and looking at how you make inclusive environments. So creating environments in where people can feel welcome, people feel respected, supported, and they're also able to fully participate. So when you say, I want to be inclusive and you invite people to the table, you also have to dismantle barriers to make sure that they can speak fully and authentically in their experiences as the same as the other people who are also at the table. So embracing those differences, but making space at the table for people to also be able to speak and speak freely. So that is what we think about when we think about how we include people in the workplace and create a sense of belonging. Next slide. Accessibility refers to the design of products, services, or environments so that people they can be usable by people with disabilities. It's really an umbrella term for all aspects of influence when it comes to a person's ability level. And a lot of times we refer to what's called universal design, so that universal design creates environments and things so that it is accessible for anyone. So accessibility is a measure of simply how a person can participate in an activity. So looking at what accessibility means, how is it visually, auditory, motor, speech, cognitive, all of the ways in which we try to make information, spaces, and experiences accessible for people. Next slide. Equity. This is the one you've probably heard a lot about as well. Sometimes it's more comfortable for people to focus on the diversity and inclusion part, but a lot of times when we get to equity, we're really focusing on dismantling systems. We're taking a really true look at the historical barriers that have put the things in place that we're trying to dismantle. And that can be a little bit tougher when we're talking about equity, I've found in my experience. But it really is looking at the fair treatment, the access and opportunity for people to be a part of systems, but also more importantly, how do we eliminate those barriers that have prevented the full participation of some groups in the first place? That is not as easy. We're talking about years, hundreds in many cases of years that have established and put these things in place. This is where I find that a lot of times this is a more difficult conversation to think about how do we make equity. Because equity to some people can feel like oppression when equity is really looking at how we balance the scales. So the principle around equity is that the fairness of treatment and people get what they need, not equality where it's equal, but people actually get what they need. Next slide. And implicit bias. So this is a term over, I would say, the past 20, 25 years that's become a lot more popular in how we describe people's thoughts and feelings and how they then manifest into decisions. And so as I stated before, we all have implicit bias. No one is, again, exempt from that. And it doesn't mean that just because we have it, that we can't do anything about it. I can assure you that we can. We do have to acknowledge it and be aware of it as well. It's a practice, it's a skill set, right? So you don't just brush your teeth once and then expect to have flawless teeth for the rest of your life. That's the same thing with implicit bias. We have to acknowledge that we have it and practice unpacking it so that we can uncover those blind spots every single day. So we have bias, that's human nature. So rather than being neutral, we have a preference, whether that's for people, things, or groups of people. So for instance, I may also have a bias for a latte versus a coffee, but that is not going to cause harm or trauma to someone when I introduce power into the situation with bias and it becomes operationalized. Then at that point, what we're talking about can be looked at as discrimination. Right? So we use implicit bias to describe attitudes that people have. They can be stereotypes that people have about other people, which we all have stereotypes. And we think about how bias then impacts the work that we do, the people that we network with, and also the experiences that we have. So again, we all have bias, but I want to talk to you a little further about how bias actually shows up in the rare disease space and in health disparities as well. Next slide. So I want to share with you a few types of unconscious bias. Let me lead with, there are many types of unconscious bias. I think it's important that we think about what bias looks like. We have to sort of know what it looks like so that we can then unpack it and address it. Affinity bias is the first bias. This is a feeling or connection to those who are similar to us. With affinity bias, if there are groups and you're in group, for instance, in the beginning, I gave you some of my salient identities. Affinity bias means that we have a connection to people who are similar to us with our salient identities, right? So thinking about affinity bias, we are more likely, and research tells us, to trust people and offer praise and rewards to people who are similar to us. We are also more likely to withhold praise and rewards from people who are not similar to us as well. So affinity bias can show up in many ways. The ways that I've seen it show up a lot is in interview settings where we say, you know, for instance, this person reminds me of myself when I was in school, and the person may not do a really good job in an interview, but we give them credit that they actually didn't deserve. Perception bias is those stereotypes and assumptions about different groups. We all have those. Halo effect is when we project positive qualities onto people without actually knowing them, right? And then the last one is confirmation bias. We tend to look to confirm information that already confirms our own pre-existing ideas. So thinking about the information that you seek out, and we tend to take that information and then get rid of information that is not confirmed. Next slide. Microaggressions. These are the things that are brief, commonplace. They can be daily, they can be verbal, environmental, verbal and nonverbal things that really communicate hostile and derogatory or negative behaviors. Marginalized people often face these on a daily basis. And even though they can occur by well-intentioned people, we still have to focus on the impact of microaggressions. Next slide. So the National Institute of Health estimates that between 25 million and 30 million Americans have a rare disease, but estimates indicate that patients may wait nearly 5 years to see an average of 7 different doctors before their disease is accurately diagnosed. So if the barrier for care is higher in general, you're going to find that it is much higher for marginalized communities. And there's going to be a lot of other social determinants that affect that and impact that as well. Next slide. So again, as we think about the intersection of rare disease and marginalized communities, genetic abnormalities and rare diseases, it's important that we think about how our participation in the health system is also going to be impacted. Next slide. So I want to give you a few examples. Oftentimes, people of color are misdiagnosed, lack of adequate medical guidance. They are not listened to actively in terms of their concerns, and this also contributes to their poor health outcomes. Next slide. I want to just give a few examples. There was a study done in 2015 at University of Virginia that found that doctors and residents thought that Black people's skin was thicker than white people's skin, and as a result, they found that those same clinicians rated the pain lower for Black patients than they did for their white patients. If I were to ask you without telling you it was 2015, you probably would have said this was back in the 1800s. It was not. But these are the things that are continuing to impact the care that is received by marginalized groups. Next slide. Transgender patients also receive barriers. The biggest barrier reported by transgender individuals is lack of access due to the knowledge surrounding their situations. Unfortunately, many transgender individuals underutilize or avoid healthcare situations altogether. Again, for many, many different reasons. We could go on and on for many marginalized groups, but I just wanted to highlight those 2 groups and some of the current research that has been done around them. Next slide. Belonging is a community effort. If you say something that you don't like, stop, rewind, and change your mind. It's okay. Commit to understanding and recognizing areas of your identity that you may have also overlooked. Create an idea plan for your organization. A plan is a start, and that's a good place to think about a needs assessment for your organization. Harvard Implicit Bias Test is a great way to get started in unpacking your own bias. Try not to center your own feelings in situations, but focus on the impact. Educate yourself. Again, this is a skill set. It's not a journey. It's a destination that we're all on. And remember, everyone makes mistakes, but the impact is still real. At this time, I'd like to introduce Keri Norris, who is the Vice President of Health Equity, Diversity, and Inclusion at the National Hemophilia Foundation. Dr. Norris has more than 20 years of experience in health equity, public health, and social justice, with a particular emphasis on health disparities. She has served as a Chief of Health Policy and Administration at Fulton DeKalb Hospital Authority and is currently working to create a health equity framework for NHF programs and services and develop culturally and linguistically appropriate programs and services to address health disparities and outcomes within our community. Dr. Norris.
Thank you so much. What a wonderful introduction. I'm so happy to be here today. So again, a little bit about myself. I'd like to talk a little bit about my own positionality as a Black woman with some privilege of being able to be considered a subject matter expert in this particular realm of health equity and having the expertise of presenting at a TED conference and being able to influence the direction in which we approach health equity. So I would like to acknowledge my own privilege before starting this particular presentation. And so a little bit of a fun fact before we get into all of the business of health equity is that I actually stumbled into the field of health equity while completing a museum fellowship. My first love is museums, and so I started there with a background there. Next. So overall, the mission of the National Hemophilia Foundation is around finding cures for inheritable blood disorders and addressing and preventing complications of those disorders through research, education, and advocacy, enabling people and families to thrive. Next slide. So within NHF's commitment in meeting that mission, we had to take a step back and say, in order for families to fully thrive through our mission of research, education, and advocacy, I am totally having to take a look at where we are. Are we reflective of the communities that we serve? Are we doing our very best in our efforts to address health equity? And in looking at that through the mirror and looking at ourselves, we took that step back and said, it's really important for us to embrace diversity, equity, and inclusion as the foundation of building our capacity to do health equity work. Next slide. So in our specific commitment to DEI, then we created a twofold perspective of looking at how we would address it internally with our own teams and employees and staff. And again, that's the capacity building, that's the education, that's building awareness, that's creating these health equity champions, and also aligning our protocols, processes, and everything else with the values in our diversity, equity, and inclusion efforts internally. And then externally, being very transparent with our partners in our national chapters and the community at large so that we are able to formulate and build trust and also build those partnerships and collaborations whereby we can then begin working together to bridge the gap in regards to health equity. Next slide. So when we think about health equity and how we got here, then we have to take a look at overall in all disease states, the disparities that unfortunately exist throughout the world and in our country in particular. And so across various states of disease and illness, we note that there are challenges. We note that there are gaps between rural and metropolitan areas. We know that there are gaps between people of color and various communities. We know that there are gaps in regards to socioeconomic status and access, right, to resources, to health services, health systems, and health programs. And the root cause of those disparities are inequities. And so we're looking at the environment, poor quality of health. We're looking at discrimination. We're looking at policies and processes around housing and being insured or uninsured or underinsured, and poverty. Again, you know, unemployment, access to healthy food and nutrition, living in food deserts or food swamps, also poor quality of schools. And we also have to look at, in access to care, the actual interaction and the quality of interaction between persons and their providers who may have some implicit or explicit biases. Next slide. So when we say, why is health equity important and how is it tied to diversity, equity, and inclusion, we have to note that it's a continuous commitment to meeting people where they are in order to ensure optimal health is achievable for everyone. It's also a commitment to acknowledging that there are historical barriers to ethical and fair access, treatment, and also opportunities. So lots of people have displayed this particular slide with the depiction of equality, equity, and liberation. And so here we're looking at equality as we recognize that everyone can't necessarily see the game or participate in cheering for the players. And so we decide equality is the best measure. Give everybody the same thing. Well, that doesn't work. And we've proved that time and time again, specifically in public health and in health systems. So then we move and we say, well, let's try equity. And equity is meeting people where they are for what they need and ensuring that their needs are met. And so each community, each individual is different because their needs are different. And so we give them what they need, but if you notice, the fence is still there. And so the fence there represents those systemic barriers that are in place where we've given them what they need and as far as accessing and being able to see and enjoy and cheer on for the game. However, those barriers are still there and they aren't fully liberated. They aren't fully free. And in the last picture, we see that of course, they are cheering on the game, but they're still on the perimeter. They're not inside. They don't have seats. They're not included. And so that's where the inclusion piece comes in, where we respect differences and we celebrate similarities, and we make sure that all voices and lived experiences are valued and at the table. Next slide. So when we think about those systemic barriers and think back to the last slide, right, where we saw the actual fence that was in front of the people. So those systemic barriers are tied directly to social determinants of health. And what we have found is that we've spent so much time on health education around healthy behaviors. Don't smoke. Please make sure you eat correctly, get your physical activity in, drink alcohol in moderation, be proactive with being protective of your sexual health and also your mental health. And so when we think about that overall, and that's the emphasis that we put on so many people, and then the blame goes to the community or the blame goes to consumers and patients, and that's unfair because as you can see with the breakout here, only 30% of health behaviors are actually tied into health outcomes. The other 70% are all about environments that are outside of our realm of control. You have socioeconomic factors as far as education, job status, your family support, if any, income and community safety, right? And then you also have your physical environment where you live. And then there's the healthcare aspect of it as well. And so when we think about the healthcare aspect of it, then we say, okay, but that's not really within our control as well. And that is true. True, you get to choose your actual provider, but the access and the actual quality of care is outside of the person's parameters of control. And so when we think about the 70% there that the individual is not in control of through health behaviors, then all of that is tied back to our actual environment. 50% of everything in regards to your health outcomes can be traced back to your actual zip code. And we'll go back to that soon. And also 20% in regards to healthcare is tied to that particular environment. So when you look at it overall, your socioeconomic factors and environment, your physical environment, and your healthcare environment are large dictators of the healthcare outcomes that we're seeing and a lot of the inequities that are tied to these social determinants of health. Next slide. Another portion that I want everyone to consider that we often skip over and I briefly talk about in my TED Talk is childhood experiences. So we're looking at particularly ACEs, so any type of childhood trauma, any type of exposure to trauma and not dealing with that. And so we can't forget this mental health aspect and tying in the importance of childhood experiences. So often we get adults at a particular point in time in our career, and we are working with them through their insurance companies, or we're working with them through their workforce development programs, or we're working with them through work and health programs that are incentivized through their jobs. That's too late. We have to intervene earlier. That's really important. Next slide. And so as I spoke about the percentage breakdowns, and we talked about the importance of the environment overall, right? 70% as a whole, when we consider healthcare, physical environment, and also socioeconomic factors. But that 50% sticks out in regards to your physical neighborhood and environment. That includes housing, transportation, parks, playgrounds, walkability, and zip code. Couple years ago, it became very prevalent. I want to say 2014, 2015. I'm walking through a conference, the American Public Health Association conference, and I see this sign from Kellogg Foundation, and I also see it at a couple other people's booths in the exhibit hall, and it says that your zip code is more important than your genetic code in determining whether you live or die. That was the exact quote. I was blown away. And so now that we have gotten an opportunity to delve into that and look at housing and look at transportation and its impact, then we are looking at how much that plays into health outcomes. Let's look at it really quickly. Next slide. Here, tale of two zip codes, neighboring zip codes, different health outcomes, huge gap in life expectancy, different racial makeups of the neighboring communities, and also different access in regards to median household income. That's one example. Another one, next slide. Again, same example, two neighboring communities with different outcomes, different healthcare expectations, and different access in regards to income and resources in their neighborhoods. Next slide. And so there are all these studies that are coming together and coming out and popping up. Everyone now knows how much place matters in regards to what exactly is in your neighborhood. Food swamps, food deserts, access to resources, access to healthcare within neighborhoods, access to safety and police systems and other healthcare systems, EMS, fire, all of those things are extremely important in dictating our health outcomes. Next slide. So the tie-in. The tie-in is DEI works when we work. When we acknowledge institutional influences on health equity and health inequities within various realms, when we acknowledge unconscious bias within healthcare provider experiences and interactions and other core team members. DEI is a continuous commitment to improving circumstances whereby everyone is at their optimal health and is thriving. Next slide. Thank you, and this is how you can reach me for further information.
Thank you so much, Dr. Norris. Such a wealth of information in your presentation. And so I wondered if we could just go through some questions I have for you around some of the things that you talked about. So when we think about health disparities and inequities, a lot of organizations are looking for ways to promote health equity. And thinking about some of their marginalized populations, what advice would you give to small organizations or medium to large organizations as they think about how they engage people in addressing health equities or inequities?
So the first thing I would do is to know your community, right? We always want to know our audience that we're speaking with. And as we begin to evaluate who's in our audience and who might be missing, it offers the opportunity to then engage those who should be at the table and possibly aren't at the table. We don't know why, if it's a historical either intimidation or historical leaving out of certain communities. And also you have to start with reflecting on your internal processes and whether or not everything within your own organization is equitable. So there's this age-old type of adage throughout the African American community called sweep around your own front door. So you can't come to me as a community member when you aren't reflective of what my needs are and I don't see myself represented in your organization.
Absolutely. Very familiar with that adage as well. So when we think about how we engage people in particular in doing sort of that internal needs assessment, we know that particularly people of color have had a traumatic history with the healthcare system, and justifiably so. When we think about best practices to reach out to people, particularly when there may be a greater distrust in different populations, what are some best practices you would say that you would give as strategies to engage those communities and maybe help break down those barriers?
So there are three things. And the first part is publicly acknowledging that maybe you haven't been fair in your engagement and that you now are focused and you recognize where you may have missed the mark with those communities. Communities just don't want you to jump into, okay, now we're going to include you. I need you to say that you recognize that I was missing at the table and that you need my expertise, because whether or not I have letters, credentials, or time, I have the lived experience. And so I need to be at the table as a lived expert, right? And then the second part is being able to tap into those key stakeholders, right? So each and every community has a couple of people that they trust, whether it's a faith-based leader, whether it is the neighborhood gossip, or whether it's the oldest person living in that community that people respect, who holds the history and the culture and the social norms for that community. You want to engage them, because when you engage them, others will follow. They will teach you the ways that you need to know of engagement and how to broach the community and establish those partnerships, right? And then the third way is making sure that you have adequate data, that you are culturally sensitive and culturally aware of the communities before you step into them as much as possible. Just walk in with cultural humility. I don't know, but I want to know.
Those are excellent points. And I can't agree with you more that the cultural humility is so important when we're thinking about trusting the funds of knowledge that people have built around their own communities and allowing that to be as equal balance of the information that you're trying to share. So thank you so much for pointing that out. I think the last question that I have is, when we think about inclusion and we think about how we bring people into these situations and engaging, diverse volunteers and diverse communities, you talked about acknowledgement being really important. What does sustainability look like in this work as we think about continuing to do it, even when it's difficult? Because oftentimes the people who are at the top leading it may not reflect the diversity of the communities we serve. And so I wonder if you could speak to that just a little bit as well.
Sure. There are elements that are more difficult than others. There are going to be communities that are a bit more harder to partner with and collaborate with than others. It's like anything that comes out that people are trying to investigate, where you have those early adopters and late adopters, and then those full skeptics who are like, I want nothing to do with that. And so the approach has to be one that's sensitive. The approach has to be one that's acknowledging of where we have missed the mark in the past and how we're going to bridge that particular gap. And so when we integrate it into our mission and our vision, into our daily work through making sure that it's a part of the strategic plan, strategic priorities, our tactics, and a part of evaluation, then it becomes a natural thing that we do on a daily. And that's the sustainability of it. When your board buys in, so you have buy-in from the board all the way to the first person that you meet when you walk through the door of the organization knows what DEI is, knows what health equity is, and can stand on it and tell you about it and tell you a little bit about how we're meeting those efforts. And so, yes, it will be challenging. Some roads and pathways will be smoother than others, but I always say difficult takes a day, impossible takes a week. So we just have to be patient.
Absolutely. Thank you so much. Some of the highlights of what you said is, one, you have to be transparent, right? You have to be transparent. You have to acknowledge there has to be accountability built into your systems. Absolutely. And meeting people where they are. The education piece is so important as well, and coming in with that humility to know that we all have space to grow individually and in our organizations. And we know it's not going to happen overnight, but we can start the process today. So thank you so much for all of the wonderful information that you have shared today. And thank you all for being here with us. I would now like to introduce Dr. Vinicio de Jesus Perez, who received his medical degree from the University of Puerto Rico Medical School and completed an internal medicine residency at Massachusetts General Hospital. He completed a fellowship in pulmonary and critical care medicine in Denver, followed by a postdoctoral research training at Stanford University. He focused on researching genetic and molecular mechanisms of pulmonary hypertension and idiopathic pulmonary fibrosis, and has devoted his clinical practice to diagnosis and management of these conditions. He is presently an associate professor of medicine and staff physician of the Stanford Adult PH Clinic, where he trains fellows pursuing careers in PH and IPF. He is a principal investigator of a research program with the ultimate goal of identifying new therapeutic targets to treat PH and IPF. Welcome, Dr. De Jesus Perez.
Thank you so much, Dr. Avent, and thank you to Nord for inviting me to talk to you today on this very important topic. A little bit of background. I'm a physician who focuses on two rare conditions, pulmonary hypertension and idiopathic pulmonary fibrosis. My day-to-day work is to diagnose, treat, and accompany the patients through this journey, which, as for many of our patients with rare diseases, is fraught with misinformation, challenges to accessing the right medications, the right medical care, but particularly our most vulnerable communities are at an even greater risk of falling through the cracks and not getting the care that they need. Now, today, I don't have a presentation, but I do have a story. And I think this actually is very informative, as it tells you some of the challenges that I, as a doctor, have to face. And I think many of you may relate to this. So a couple of years ago, I received a call from a community physician who cares for a large Hispanic population. This is an individual, a good friend of mine, who had referred patients to me in the past for assessment. Quite patient was very sick with pulmonary hypertension, and this patient had been in the medical system for at least 3 years, where the patient had been receiving misdiagnosis, no diagnosis, or simply no attention whatsoever. What complicates the picture is this is a patient that is uninsured, it's undocumented, and Hispanic. Works at in a fast food setting, minimal income, and lives with a family of 7 in a 1-bedroom apartment. Okay, this is unfortunately not a rare situation here in the area where I work in California. The patient was really disappointed. She was only told that she needed to get ready to die because nothing could be done for her. And so the doctor that referred the patient to me was her family doctor, and had advocated strongly for the patient, and had difficulties finding within the medical system advocates, champions that will be willing to take care of the patient, or to try to work through the financial and social barriers that were inherent to this patient. So I of course acknowledged the need to see the patient and was able to bring her in. And one of the first things that impressed me, and this is something that unfortunately is part of the experience of many patients who belong to underserved communities, is her her lack of trust in the medical system. And I, as a doctor, obviously being part of that medical system, the first thing that I had to offer to the patient was try to create a bridge of trust so that we could at least communicate and develop a doctor-patient relationship that will help us move forward. And for me, this was very critical. As a physician, I understand that, especially for Latinos, the cultural context, the family, the community is vital, and it needs to be acknowledged during the discussion of the healthcare issues. So as we spend, and this was probably hour and a half of talking with this patient in Spanish, which really made the patient feel validated in a way, because she felt that she could actually speak. When I asked her what was her major goal in life, if she could get her health back, what will she want? What she told me is quite different from what you will expect from other patients who will say, well, I would like to go and golf, or I want to travel around the world, or I just want to stop using oxygen. Patient was using oxygen. She was significantly deteriorated. Her major wish was to have a baby. Why? Because everybody in her family, all her sisters, had children, and she, given her condition, had not been able to carry out this. And this was so important. So for this woman, being healthy, being able to tackle her rare disease, meant to be able to get to that point. Now, there's many issues in this case that I think reflect many of the challenges that I, as a physician, have to face. Number one, patients who are Hispanic or who belong to other underserved communities, whether they're African Americans, Native Americans, Asian Americans, who do not speak the language, who have not come to the point of essentially becoming acculturated to the American society, are quite vulnerable because they do not know how to navigate many of these many of our very complex healthcare system. As a physician, the first thing you need to do is become an advocate, and you need to identify colleagues who will be advocates. Taking care of a patient with a rare disorder is it's a job that involves a multidisciplinary team. So for me, one of the key things to care for these vulnerable patients is to identify individuals who will be part of the care team who are all committed to that patient. Number two is to identify the resources that that patient will need to support himself or herself in the community. There's the part that we have to attend to, which is the health insurance, medication coverage for healthcare. The other thing, and this is something that we may not think much about, is also how we incorporate the support base of that patient into the care. In this particular case, remember, she said how important it was for her to be pregnant because she felt she was a disappointment to her family, to her community, for not being able to carry out the role of motherhood, which is so important in the Latino population. So without the support of the family, I knew that this patient will not get the initiative, the energy to carry out the hard work of taking care of the pulmonary hypertension. So I had to bring in the family into the room. Large family, we're talking almost like 15, 20 individuals in a room, because that's we're talking about incorporating the family in this, and this was the entire support group for this person, and to educate them about what the disease is, what the challenges are, what to expect. That made a significant difference. But this was all me. And I can tell you, many colleagues will have a difficult time because they don't speak the language, or they don't have the actual time or the support. So a big part of the work that we've carried out forward is to develop materials in Spanish that we can share with the with family members, particularly when it comes to small webinars, presentations in in simple English that can be understood, or in Spanish, so that the patients can actually relate to the what the patient is going through and become engaged in that patient's experience. And this is something where having patient advocacy organizations like the Pulmonary Hypertension Association, PH Aware, for example, Team Phenomenal Hope, becomes crucial, because you now connect the patient and their families to a larger community that can provide the support that they will need, while me as a physician can center on providing the medical care plan that the patient will require to carry out the work. For this particular patient, the outcome was actually quite excellent. Over the years, we were able to secure her access to life-saving medication. She was able to get medical, and we gave our best. And ultimately, she needed to get a transplant, which she finally was able to get through. By the time she was ready for transplant, she was a different person. She was active, she was optimistic, and her whole family was for her. So she was successful because we were able to provide all of these interventions. And it, beyond what I could do medically, I knew that having the family, having resources, having patient advocacy groups all together were part of how this patient was able to go through transplant and be alive today. So the message here is that I, as a physician, taking care of these populations, you need to identify very early on community advocates, or reach out to organizations and connect that patient so the patient doesn't feel alone. You need to ensure that there is an opportunity for the patient to speak their language and to be able to communicate. if not through you as a Spanish speaker, to actually have a translator there, and to remain committed and in communication. This, for these patients, is crucial to know that you care more so than for other patients. You need to show that you are involved and that you're committed. And I think ultimately this is something that our medical system needs to potentially improve upon. But thanks to the involvement of patient advocacy groups, as well as other professional organizations, it is possible now to propose that this is a feasible plan for that can potentially benefit these vulnerable patients who are seeking our care, which, if they don't get to us, they may actually be missing what could be life-changing therapies and potential to get back to their life, and get a chance to be with their loved ones, and to you know get the most out of their life. So with that, I'm going to stop there and see if you have any questions.
Thank you so much. That story was so touching, and I thank you for the work and honor the space and the service that you gave that patient. And so you spoke to so many different areas that I want to address. One of them is particularly the way in which you approach the unique situation and the intersectionality of the needs that this particular patient had, right? You talked about them being undocumented, uninsured, Hispanic, and also how their family was really important in that approach. A lot of times patients don't know how to best advocate for themselves when they come into the healthcare system, especially if they've had bad experiences in the past. They can be very vulnerable. What is some advice you would give to patients and families as they continue to seek care to best advocate for themselves, even when they're presented with being turned away or not the best conditions? What advice would you give?
So I think it's important for the patient to identify what the support base is. First and foremost, the physician and the group of physicians must serve as strong advocates, but that's only half the battle. For a patient to truly benefit from the medical care, the family also needs to be part of that equation. In this particular case, the patient was very anxious because she didn't understand what she had. So how will she be able to explain to her family what she had? I mean, a rare disease nobody has heard. This is not like high blood pressure or heart attack. So how do you explain that? So the first thing was to educate the patient. So for the patient to know that they have a real disease, that it's a disease that needs care, and that it's not in their head, and it's not something that's just gonna go away. For many patients, I mean, it sounds a bit condescending, but the fact is, if it's a rare disease, and nobody has heard about it, then the patient will not get anybody to relate to it, right? So if you first explain it to the patient, so the patient is truly convinced that, okay, I know what I have and I know what needs to be done, and it's real. I'm gonna talk with my family. So for that, I usually ask the patient to bring the family in, because as a physician, I do have a level of authority that will help the patient when they are talking to the family to believe and to take more seriously the situation. And I think that's a part of the dynamics of dealing with these patients that is important. You also want to try to bring in that other side, because the patient spends more time with the family than they spend with me. So it is vital to be able to first educate the patient and convince them that it's not in their heads, it's real. And the family should understand that this is real. And if they're having trouble convincing the family or their community, then it is my job to provide them with information. If they cannot meet with me, provide them with tools. pamphlets in Spanish or videos that I can relate to so that they can share with the family and they can become engaged.
Absolutely. And that language access barrier that you talk about is so important in affirming people's spaces and the need to have a diverse way to communicate with people and to meet can't highlight enough how important that is. Before they even can hear what you're saying, you have to show them that you care. And so a lot of times people are dealing with past experiences that have left them feeling less than or deficient. And so you have to stand in a space and make them feel so that they can feel appreciated, so you can actually be heard, right? So how do we reach people of color when they have justifiable reasons for not trusting the medical system based on past experiences and historical trauma?
I think you have to give them the opportunity to express themselves, and they have to tell it to you. I mean, I've had circumstances with patients, whether they're African American, Hispanic, or Asian, who they already come with a wall between the patient and me, and I already can tell, like, you can cut the tension in the room. And as a physician, I have become, with experience, less intimidated about that, and I'm more vocal to sort of like ask the patient, I can see that, you're hesitant in terms of, like, asking questions or like providing me with information, or I can see you're detached. Can you tell me what's going on? And more often than not, patients will just let it all out. And initially, especially if you're a young doctor, sometimes it can be quite intimidating or even disappointing, because a lot of this happened not because of you. It happened in the history past, but you're the doctor, you're sitting there and you're just getting all of this rage, all of this anger, frustration. But I think as a physician, you have to understand and you have to recognize that there are mistakes are made along the way, and this is more often than not part of the experience of these patients. And for me, it is important to just listen to the patient, because I think that's the problem, that these patients have not been listened to. They're being told to, or they're being talked over. So first is let them speak. And once all of that is out in the open, you do have to be very honest with them and just tell them what you can do, what you cannot do. But I think at the end of the day, I always may emphasize that, listen, I cannot promise I'm going to cure you. I cannot promise that the disease is not going to progress or that the medications are going to work. But what I can promise is, in this clinic, with my team, with the resources that I have, I'll do my best to take care of you, and I will always tell you the truth. So if we hit a point where I cannot do anything more for you, I'll be the first to tell you. But, I will definitely, I can offer you the truth. I cannot offer you that everything is going to work out. That's not the way it is. And, I think that's, I just really want to make sure that the patient understand that, this is challenging. I'll do my best. And I'm not expecting the patient to give full trust, but at least to give me the chance so that we can build that trust.
No, I think that's so important. And can I say that I'm excited and happy that you're in a space where you're training others to be able to do that. I think when you let people speak, you're not only helping the patient and listening, and like you said, it can be uncomfortable, but you're helping yourself, because patients are probably more likely to take the medication that you prescribe and to do the things you ask them to do versus just not doing it and also not telling you. So thank you for that. The last question that I have is, what are some barriers that individuals or families face in genetic care? And what are some specific ways to address these barriers?
This is a really important question, one that I'm not sure I have an answer, but it is something that we're actively interested and researching. For example, in my particular area of expertise, which is pulmonary arterial hypertension, there is a strong genetic predisposition in certain patients, and we can identify that in certain families, and in some cases, depending on their clinical picture. And you know, we don't routinely offer genetic screening to all our patients compared to other countries like in Europe, where this is actually run of the mill. One of the biggest challenges for why we are not able to do this in particular is not necessarily, one is the cost of getting the genetic testing, but also the fact that genetic testing also comes with a huge baggage of that involves, you know, if the patient has a genetic mutation and that genetic mutation is being passed on to children or to their other family members, then it opens up a lot of questions. It can lead to guilt, it can lead to anger, it can lead to frustration. So that's one of the things where I think having a genetic counselor becomes critical. And again, going back to the major challenges of taking care of these patients is, you know, if we're having issues communicating with the patients and providing them with the support they need, to be able to provide them with a genetic counselor that can speak in their language, that understand their cultural and ethnic background and all the things that go, is also particularly challenging. So to identify genetic consultants that are able to carry out this work in conjunction with the doctors in a way that is culturally sensitive, that recognizes the value of community, the implications of genetics on family, on traditions. These are all important. These are all important things, because I can tell you that a patient with pulmonary hypertension who gets diagnosed with, you know, the unborn child gets diagnosed through genetics with one of our mutations that may be associated with the disease. Well, you know, in many cases, those patients will be offered to have, you know, to have an abortion if it's at the right time. That is not an option for many patients, particularly in the Hispanic community, where most of us are Catholic, and this is not so. You know, this is not, you know, you cannot bring that up and force the patient to consider that as the only so there are factors here. And, you know, to me, I think this is an area of unmet need. I don't know what the status is, and I'm sure that NORAD is involved in this, how genetic counselors are tackling the education and care of these populations. But I think personally, that's an area of unmet need. But for me, you know, I think that's the major challenge beyond the medicine is all the counseling that that family and the patient will require moving forward. To me, that's a huge unmet need, and I don't know at this point in time how far along we are in terms of addressing that.
Very important for that holistic approach, which is what you keep underlining, that there needs to be a holistic approach, as well as a culturally relevant approach and practices with dealing with our underrepresented and marginalized and most vulnerable populations. So thank you so much for that information. And now we will have some live questions from the audience. And so I will now pass it back over to you, Debbie.
Thank you so much, Dr. Avent. That was an incredible presentation. We actually have gotten very close to our time. So in the last couple of minutes, I want to thank our panelists. And, you know, we did have a robust Q&A during the presentation themselves. So I just want to ask Dr. Norris, Dr. De Jesus Perez, and Dr. Avent to just give some parting words because we've only just started. So if you could give some feedback based on everything that was shared, We'll start with Dr. Norris.
Thank you so much, Debbie. It has been my extreme pleasure to be a part of this webinar, and the valid points within Dr. Avent setting up the foundation of what do we mean by diversity, equity, inclusion gives us the foundation for how we should always describe what we mean by those things and how we should set up our foundational structure for how we're addressing those things. And then moving into how that foundation then dictates how we put together services and programs and who's included, and making sure that we're using that lens of DEI in everything that we do to ensure that no one's left out at the table, that we have everything that's missing, and so we can make those right connections. And then ensuring that with fully understanding the communities we're working with, then looking at Dr. Jesus Perez, being able to say, these are our support systems. Support systems don't always look the same for each and every individual, but we recognize the importance of social networks, the importance of tapping into resources, the importance of making sure that the whole patient is being addressed, because that's really what's going to get us into the space of reaching health equity by implementing DEI. Thank you.
That's a wonderful summary. Now passing it to Dr. De Jesus Perez.
Yeah, I think it's very relevant right now to make sure that we are really paying attention to our patients' needs, particularly those that have historically been underserved. I mean, the social climate has certainly made this more urgent, but it's always been an issue. And I think as nonprofits and as we strive to provide the best support and be best advocates for our patients, I think it is critical that we can work together and improve the resources that we currently have as sort of low-hanging fruit to make sure that our patients are receiving the best options to receive the level of care that they deserve.
Thank you, Dr. De Jesus Perez. And finally, last but not least, Dr. Avent, any parting thoughts?
Yeah, I just want to say it's been a pleasure to serve on this webinar and working with NORD. And my colleagues have said such wonderful things already. The only thing I would add is that this work can really be overwhelming if you're starting to begin to dig into this work. So what I would suggest is really take it step by step, right? There are micro things that you can do. Education is going to be critical. So educate your community, educate yourself, identify where you stand in your identities juxtaposed to your community, and understanding that can be really helpful. And set goals. Set goals to know where you're going. You have to have a vision for where you're going, because that's when it can become very ambiguous and overwhelming. And so again, take a needs assessment of where you are, help people, educate people in your groups around implicit bias. Again, around basic terminology can be really helpful. What we want to do is have words that can empower people, because words can also be weaponized. And so when you have a common language around DEI, it helps advance the mission for everyone and not just a few individuals. So again, I think that once you get into this work and continue to work with your community and build trust within the community of your organizations and set your goals, that's a really good place to start.
Thank you so much. And that is all of the time that we have. I just put in the chat our next webinar, which is on inclusion, looking at barriers, who's left out, and building an inclusive community. We had so many wonderful questions and participation from the audience. Thank you so much to our panelists. We hope that you come back in 2022 and speak with our members and our patient advocates again. My name is Debbie Drill. You can reach anyone on the NORD membership team by emailing membership@rarediseases.org. While we will not be sending out slides, we will be sending out the recording of this webinar. Sign up for NORD's e-news. Follow us on Instagram, LinkedIn, Twitter, and Facebook. And see you all next week. Take care, everybody.